Welcome, everyone. Thank you for coming. This is our first healthcare speaker series event for this academic year. I know many of you, but I'll introduce myself anyway. So I'm Matt Odowadigdo. I'm a professor of economics here at Booth, and I'm one of the co-directors of Healthcare Initiative along with Dan Edelman here today. The two of us launched the Healthcare Initiative a few years ago, and one of the things that we've been doing is running these speaker series events. We're going to have a conversation for about 30-40 minutes, then open it up for questions and try to make sure we end a few minutes early for those of you that have to head off to class top of the hour. So that's the plan. Good. Anything else about the Healthcare Initiative? Okay, great. So let's go ahead and get started. So I'm delighted to be here with Catina Latham. She has two roles, according to my notes. So she's the acting director at the USGAO, that's the Government Accountability Office, where she does work with healthcare teams. And she is also an adjunct assistant professor of healthcare management at Booth. And in that role, she is teaching a health policy class that will be offered this winter. I should have advertised my own class too. So we're here advertising both of our classes. So I teach a health economics class in the spring. I don't know the course number to that one because I didn't write it down. But your course number is 33352.
Thank you. I was going to say, I don't know mine either.
Which is understanding the health policy forces driving the U.S. healthcare system. And Dan Edelman teaches a healthcare data analytics class. So we're building out the healthcare curriculum, and you have two of the healthcare instructors here with you today. Okay, so I thought we would get started by just letting you spend a few minutes talking about your journey, your professional journey, maybe starting from college up till the present day. Anything you want to highlight for the group, and we can get started from there.
Okay, well, first of all, thank you for having me. And thank you for sharing the information about the course. I'm excited to teach it as a new course, and we can talk about that a little bit later. But first, to the question that Matt asked, who am I? What's a little bit about me? Well, actually, I started at the college at the University of Chicago time ago. We won't say when, but I thought I wanted to be a science major, and then I found my way into anthropology. And in that came out this interest in sort of health and culture and diversity and just understanding how to do that. And I thought I wanted to do a career promoting health. Just knew I wanted to just like get a master's of public health or something. And so I landed my first job in Nashville, Tennessee, working at a health center. And I was doing health promotion, health education for senior citizens. And at that time, the state of Tennessee was doing what's common to us now, but was innovative then. They were enrolling all of its Medicaid managed care beneficiaries, all of their Medicaid beneficiaries into managed care. And as you can imagine, having a senior population, I got tons of questions on what does this mean? Can I still go to my doctor? They're telling me I can't. Where do I go? What do I do? And so I thought, okay, well, I need to inform my seniors. And I started going to these meetings that the state hosted for the public to understand what was going on. And I fell in love with the Medicaid program, with the whole process. Of course, I thought at that time, they're doing it all wrong. I want to find ways to fix it. And I thought, well, although I love the direct interaction I had with the seniors each day, I decided the seat that I wanted to take at the table was at the policy level and much higher up. So then I pursued a master's program in health service administration. So I was like a lot of you. At the time, I was at George Washington, and they had a new School of Public Health, but its Master's of Health Services Administration program was kind of still housed in the business school and moving over to the School of Public Health. So I took a lot of the same courses that you all are taking now as part of this concentration, but I still wanted to do health policy. A lot of my classmates, though, went into health administration or consulting. But I pursued the route of health policy and started working at the Government Accountability Office. And I started with their healthcare team, started doing work on Medicaid, and also, as some of you may be familiar with, the state children's health insurance program. So I did that for a few years and moved around. I was in the DC area, moved from DC, went down to our Atlanta office. And then I went from Atlanta and came here to Chicago because we have the Government Accountability Office has 11 field offices. And it was something about when they sent me, congratulations for 15 years of public service that I just thought, I got an itch in my pants. It's like, I was only supposed to be here for like 3 to 5 years. And so I decided to pursue other opportunities. And the first of which I worked with the state of Illinois Medicaid program for a couple of years, which was phenomenal. It was phenomenal to be able to work directly involved into a program that I evaluated for years. After leaving that, I also went and worked at the University of Chicago Hospital for a couple of years. And there I got a chance to do more community level work. So I'm very thankful that I've had the federal, the state, and the community level perspective. And about 4 years ago, I got the opportunity to rejoin GAO as what we call our senior executive service. And they took the acting part off. So I'm now a director within the healthcare team, and I lead our Medicaid portfolio. So that's me in a nutshell. Sorry, I
That's
didn't mean to
perfect.
give my
That's
whole
perfect.
life story.
No, I think there's a lot we can go back to, but that was great. And I think one of the tough things about getting interested in healthcare is that there's a lot of institutional details kind of have to sort out. So you mentioned Medicaid managed care, just so that everyone's on the same page. Can you give us your quick summary and kind of perspective on how that happened and where it went?
Okay, well, I think it happened because, well, clearly for those of you who know, the private sector was going that way, where the employers were saying, well, we're going to provide you health care with this plan, and we're going to pay a rate per member per month to this plan, of which in the private sector, of course, the beneficiaries share in that per member per month rate. But I think it was the notion of we're going to manage or coordinate or organize this care for you. And it's felt that it's had great success in the private industry, which, that could be a subject open for debate. And so since it was going so well for the private market to do what we like to call in healthcare, the three-legged stools, controlling cost, quality, and it's cost, quality, and access. Thank you, access. And so since it was focused on all those three things, it's thought to be a well-managed tool. It's now predominantly in the Medicaid world with the hopes of having that same success. And the reason why I said it can be debatable, and this is something that I think I look forward to talking about in my course, is the Medicaid population is so vulnerable. And is this really the best vehicle to manage their care? But like I said, many argue it provides that coordination that's needed, as well as ensures the access, because once a provider is contracted, they are required to provide the care to the beneficiary. And it allows some quality. I think that's the reason why we've seen it in the public sector, not just for Medicaid, but also for Medicare. And I understand for Medicare, they love it.
Mhm.
Have this announcement.
But do you have a story of how did it initially become popular? So you're saying it's because it was working in the private sector that Medicaid decided, let's try to bring in this idea of having the private plans involved. It was sort of motivated by the fact that it was working well in the private sector.
I think it was motivated, yes, as both a cost-saving measure and access guarantee, but then as a means to ensure quality. Because prior to managed care for any sector, you could go in and receive whatever care you needed, go to whatever doctor you wanted, but there was no one really there sort of held accountable for managing that care, making sure that, you were receiving the right referrals and that information came back to your primary care doctor or to your medical home. So I think that whole concept was believed to be beneficial for the Medicaid.
Well, can you tell us a little about what the day-to-day work is like at GAO? What are some of the projects you've been most excited about?
Well, good. Before I get into some detail, how many of you are familiar with GAO? All hands raised. Well, okay,
Yeah,
well, good.
Let's start at the beginning.
Yes, no, I'll start at the beginning. Well, the Government Accountability Office is the research arm of Congress. So when you hear on the news a congressional study, more than likely it was GAO. And we are firmly vested in the legislative branch, so we're not part of the executive branch. We have a comptroller general who leads the agency, he is sort of, that person is identified or by Congress, but then selected by the president, and he or she, because his term will be coming up soon, but the current Comptroller General is Gene Derdero, and he serves a 14-year term, which allows us a great deal of longevity in planning and addressing the needs for the federal government. We are the watchdog and the research arm of Congress. And that means Congress will come to us and say, in my case, I lead the work on Medicaid. They can ask any and everything that they want for Medicaid. They can put it in law for us to study. They can give us a formal request to do the study. Or they can also, we have the right to also say, go to them and say, we think this is an emerging issue. We'd like to do it. And that's the work we call is under the authority of the Comptroller General. So I've done everything, fill in the blank, Medicaid, you name it. I've done the work. I've done a lot of work in Medicaid managed care. I've done a lot of work in Medicaid and even just access issues, quality issues. I've done a lot of work in Medicaid and demonstrations that states do. And we don't just do healthcare, obviously. We follow the money. So every federal dollar source you can think of, we have a team. We have about 11, 12 teams, not just healthcare, that focuses on those issues. And I think some of the benefit, as I mentioned, that people enjoy about the work that we do, we are able to do some of that long-range planning. We make recommendations to Congress that we track and make sure that the agencies are implementing. And since, as you know, when the executive branch changes over administrations, we're still there doing our work. We do have a lot of fluctuation, though, when Congress changes, but it's important for us to maintain the relationships with staff and to be ready for that turnover. As you all know, we're preparing for that now as we're anticipating some turnover this upcoming year.
Great. That was very important for me. I think I've seen GAO reports over the years. What are some examples of ones in the Medicaid space that either you're particularly proud of or you think were really influential in terms of like the policy impact or how Congress thought about things?
Yes, I think so. As I mentioned, we've done a lot of work in Medicaid managed care. We've also done a great deal of work. There's a saying, you do Medicaid work when you've seen one state, that's just it. You've seen one state because all
I love that.
Yeah, I do too. I love it. I say it every time because that's what attracts me to the program. It really does. You get to, it's like 50 innovation labs going on, plus the territory, so 54, going on all at one time. And it's amazing, as I got to experience in Illinois, to see how states are designing their programs to meet their patients' needs. And states are given a great deal of flexibility. It's a 50-50 partnership. The federal government pays its part, and then there's a formula to determine how much state pays, like the state of Mississippi pays less than probably the state of New York, as you can imagine, given the financial management and issues that the state of Mississippi may have compared to New York. So in that range, you can do a lot. Have a state plan, which is like, that's the state's task to say, this is how we're providing care. But you can do a wide range of things. Like what I mentioned in Tennessee, that was innovative for Tennessee to step out and say, we want to move everyone to managed care. And to do that, they get what's called waivers. And that's allowing them to waive some authority in the Social Security Act. In fact, like a waiver is called 1115. And it's literally saying we're waiving portions of Section 1115 in the Social Security Act. Now, that's where I'm the most fascinated because that waiver allows states to do the most innovative, far-ranging things that they want to study. And that's what Tennessee, that was the vehicle they used to go on managed care. Just about most states have it now. I think there are over 30 or 40 states that have managed care. But what I like to study about the waivers is that they're demonstrations. And so demonstrations in and of itself means kind of test, temporary, but unfortunately, that's not what's happening in reality. In reality, you're having more permanent things that are in place, but they're still under these demonstrations. And I think one of the most interesting works that we've done is sort of pushing the executive branch to think about these demonstrations and think about if you're testing and evaluating them, making sure that evaluation is rigor, because they really are supposed to be testing models to learn what can you then bring back to the fold for all states to benefit. So while I love the concept of having all these different models, I feel as though and that's the work that we've done, is sort of pushing the federal government, Centers for Medicare and Medicaid Services, who oversees the state, pushing them to say to the states, hey, what can we do? What can we learn from these evaluations that we can then bring back to the fold? And I think it's great work, and they should continue to do so. But some of the work that we've done at the GAO that I think has helped to influence policy has been pushing for that rigor in the evaluation, pushing for that return on the loop of the information that's learned through those evaluations, to then ultimately help the program as a overall.
Great. So does the GAO help in evaluating some of these waivers?
No, actually, our role is would sort of be evaluating or seeing to what extent the oversight is in place by the federal agency. All the evaluations, as part of the requirement to be approved, has to have like an external entity to do the evaluation. So organizations that you might be familiar with in the health policy space, a lot of them may take on that independent role of doing the evaluation. In some cases, it might be the university that's in the state, that the state may contract to do this independent evaluation. Our role is just to see if the federal agency, which is CMS, is doing their part to oversee the process. I mean, we may make comments, like I said, we'll make comments on whether or not we feel that there's a rigor in place for those evaluations, or if the federal agency is doing its steps to monitor those evaluations or to take in the results. But yes.
Well, what's an example of a waiver that you thought was particularly innovative, creative, exciting? Or maybe on the other hand, what's a waiver that you thought maybe shouldn't have been approved?
I don't know if I can answer that one. No. But no, one I thought was innovative. Well, of course, Tennessee always stands out because it's one I was in the midst of. But the state of Hawaii, really, I thought was working on its waiver, and it's one you can go and research. It has transformed over the years, but they did their waiver shortly after Tennessee. They went through a model where they were trying to sort of mimic what's the same, what we have in private health insurance. And so I just thought that was an innovative way to, I think their ultimate goal is perhaps find ways to provide universal health care, but also to, like I said, trying to make it as common or as the same as with the private sector. And so I thought that was, I think that's pretty innovative.
So when we were preparing for this, we talked a bit about telehealth and based care. Is that something that you think could be addressed through one of these waivers through the Medicaid program, or what are you sort of seeing on the ground in terms of how Medicaid's going to interact with telehealth going forward?
Well, the pandemic helped there a great deal. Prior to the pandemic, both Medicare and Medicaid did not have as much telehealth access, but as we all know, it forced everyone into looking into remote options. And so now that's an option that's available for care for Medicaid and Medicare, and states are using it for their Medicaid programs in particular. I should say Medicare is managed at the federal level, whereas Medicaid is at. And so states are allowing beneficiaries to receive care through telehealth. I think the other side of that, though, is the monitoring needs to continue to be there to ensure patients are, in fact, receiving the care that they should receive, to ensure that patients, if they want that face-to-face, that's allowed too, and that providers not just continuously offering telehealth. So I think that's something that's here to stay. It would be my personal opinion for the Medicaid program. And I think that states are using that to increase access, particularly to like mental health, particularly to individuals who live in rural areas who may not be able to frequently go to where their provider is. So I think it's a great tool that's now been added for the program that has helped to increase access. Regarding home and community-based services, the same there. During the pandemic, they were allowed to do sort of telehealth there or modify the services there. Now, home and community-based services has pretty much gone back to as much as possible to the way things were before the pandemic. As you can imagine, it's because the person needs that day-to-day care in the home. But home and community-based services as a whole are increasing because more and more people are desiring to stay in the home and not to remain in institutions. And there was also a law in place, as some of you may be familiar with, called the Olmstead exemption, where it is requiring you to help the individuals stay in the home or receive the care in the manner that they wish to. So I think with the push to meet patients' needs and their desires, we're going to see more and more openings and avenues for home and community-based services. As you all may know, now Medicaid beneficiaries, they can have family members to take care of them and the state cover that cost. I mean, if you can. Unfortunately, not every situation is stay in the home. And then that's the discussion that the patient then has with their provider. But across the board, all of the states are, and there are waivers in place to allow that as well. States are doing whatever they can to meet the patient's needs to allow them to stay. I think that's been a movement that's been positively received by everyone.
So one of the things I read about when I study Medicaid is like the difficulty of getting doctors willing to accept Medicaid patients. Any thoughts on what Medicaid could be doing differently? Is it something that should be tackled at the federal level, or let states experiment ways? What are your thoughts on how to improve the situation?
Yes, well, if you talk to providers, everyone's going to say it's the reimbursement. They feel as though if Medicaid is just a low payer for them, they feel as though if I'm just giving out an example, maybe for a visit from a private insurer, they may get $100, but a Medicaid patient, they feel they may get much less than that. Let's just say throwing out a number, $60 or $50, and they feel as it's impossible for them to financially maintain receiving that level of reimbursement. I wish I could answer that question, because then I feel like I'd be rich to solve that problem. But I think it's a combination of pieces that the Medicaid program is pushing now. And that's the notion of like value-based purchasing, where providers are getting, the reimbursement that Medicaid can give, because there are financial constraints. That's a reality that we have. But depending upon me reaching certain quality metrics, they have the opportunity to receive more money. So I think that's the tool now that is, being widely used for the Medicaid program to be competitive in the regular market. And then that's ensuring the accountability that the Medicaid program needs to ensure that providers are providing that quality care. So if you're a provider and let's say you focus on maternal health and you're making sure that you're meeting the metrics of patients coming in for their visits and which a provider would do, that would be their priority. But if you're focused on those quality metrics, there's an opportunity at the end to receive whatever the value-based arrangement is for receiving the quality. I think that's the big tool.
And these quality metrics, I'm guessing, vary by state. So different states have different metrics.
Different states can.
They think some of them have come up with a better set of quality metrics than others?
Well, most states, I would say, are probably using, there's a national, it's called NCQA, National Committee on Quality Assurance. So they have metrics that are standardized and that are comparable across states and to national benchmarks. So those are the predominant measures that are being used in these arrangements. But to your point, Matt, states can have their own measures. The state of Illinois for a while was using some of its state measures that they were pushing, because there may be different things that are not covered by NCQA that you want to use. But I would say, and I would think it would be recommended, that those would be the metrics that you use to sort of monitor that quality, because then all health plans, that's the language that they speak. Those are the measures that they understand. They know how to collect the data. They know how to follow the procedures that are in place by NCUA, the entity. And so that's, I would think, is the way that they're going about assessing.
So we talked a bit about the healthcare workforce. That's something I've been interested in recently. So some of you may know this already, but during the COVID pandemic, it was the first time in my lifetime that the healthcare workforce shrank. We used to say healthcare jobs were recession-proof because every recession in my lifetime, the 80s recession, the 90s recession, the Great Recession, in every case, healthcare employment just kept chugging along. It looked like a line. You just plot it's going. It's recession-proof. It's not like manufacturing. It's not like construction. Then the pandemic hit, and we lost hundreds of thousands of healthcare workers. And it seems like it's taken quite a long time for the healthcare workforce to be rebuilt. What are your thoughts on what to be doing going forward about that?
Yes, and I was at the height of the pandemic. So I understand it personally because even staff that I work with, burnout was real. And also I left during that time too. You know, incidents like that sort of help you come to this moment of what do I really want to do in life? And I think that's a moment a lot of doctors face, nurses face, in addition to the stress and the impact. I think and it was an issue I think that faces the healthcare community as a whole, that notion of burnout. Because it's a heavy weight to care for someone, particularly if you're in a situation where you're experiencing or seeing trauma they may be having, death or long-term illnesses. So that's a heavy weight. And so I truly believe that they are miracle workers and first responders that we need. I post pandemic though, I feel as though if hospitals particularly are thinking about ways to lessen that burden, thinking about how to do the shift schedules for nurses. I've heard some hospitals are thinking about ways to maybe that there's a person that you meet with virtually while you're in the hospital for some things, and then that helps to reduce the burden on the nurses who are on the floor. There's also ways of thinking about there could be different levels of care for you. Not everyone has to be an LPN or an RN or MD or what have you. Could there be community health workers who can, help you once you get to the home? So then, when they're able to release you from the hospital, there's less burden on them in terms of caring about or worrying about the transition. So maybe some people can go home earlier as a result of having that care provided in the home. So I think there's just many different creative ways to think about lessening that burden on the healthcare system, and more importantly, to making it desirable so that people don't feel that constant burnout.
Suppose I was running a Medicaid managed care plan. What should I be worried about over the next 5 years? I guess worried about from a regulatory perspective and also just worried about in general in terms of future of healthcare.
I would say the concerns about the cost, the rising, is the big issue, and how to address that with the needs that you have. I don't necessarily think of this as a worry, but if we were running a managed care organization, I think we would have to look at ways to collaborate more with others, and particularly those who are out in the, particularly those who are providing services and help individuals. That to me is the wave of where the Medicaid program and healthcare is going in general. I think it was already there before the pandemic. I think the pandemic opened our eyes to the fact that healthcare is not just about checking your blood pressure, checking your A1C levels, or exercising and all that. Healthcare is about, do you have housing? Care is about, do you have transportation to take you to and from your job so you can pay for prescriptions that you need? Healthcare is about, do you have all the support services around you if you were a new mom? But I think that if I were I would connect myself with all these partners so that the burden is not just carried on the plan, on all of us, and how do we work collectively, help this patient to keep working, happy, whatever. Could be setting up childcare. So it's just expanding that definition of what healthcare is, I think is a challenge that.
I would put a lot of that in social determinants of health. I don't know if you feel the same
Yeah.
way. And so you're suggesting that the plans could try to address some of these, I guess,
Yes.
like food as medicine and transportation barriers. And, to go back to what we were saying earlier, would they need waivers for this? Like, what are their restrictions?
They do need waivers. That's another debate because people feel as though if the Medicaid program is just there to pay for healthcare. So yes, they would need waivers for this. And I think, like I said, plans have been, and the states have been addressing this all along. It's just now becoming more apparent. And like I said, even before the pandemic, but definitely in the pandemic, that these are needs that need to be addressed. But yes, a lot of states have pursued waivers to go beyond the definition of what's healthcare.
How do the plans compete with each other? It's something I've always tried to figure out. So South Carolina is a state that I was working with a few years ago, and one of the plans does called the First Choice Fit Football Camp by Marcus Lattimore.
Oh my
goodness! I think he holds the rushing record for South Carolina.
That's not fair because football is life.
So I think it's a pretty good. I think it's a pretty good perk. But it's made me wonder, like, what's the scope of the space of strategies that the Medicaid managed care plans use, try to get people to pick their plan instead of one of the other plans? Because I think in most states consumers do have some choice when they sign up.
They do. They can pick their plans. I mean, plans have a lot of leeway. I mean, they're given this contract to provide the care. And so they have leeway for what they can use that money to pay for. I've seen, of course, plans in some cases, let's say if dental care is not covered, that's more so on the Medicare side, but a lot of states do cover dental or Medicaid, but maybe they'll cover a service that is not necessarily part of the tradition of the Medicaid program. Like they have a little bit more flexibility in what social determinants of health they can provide. I've seen plans when you're having a baby, you can go to this plan-wide baby shower and they flood you with all the things that you need for having a baby, or just additional services that they may provide for when you're a new mom. So plans have a lot of flexibilities in terms of different perks they can provide to members, how they can sort of market them.
Great. Okay, I'd like to open up for questions in just a minute. So my last question is, can you tell me the pros and cons of University of Chicago having its own? Like, what if we thought about that? What would you tell us? Like, what would you tell the leadership at University of Chicago? Is that a good idea? Is that a bad idea? Does it depend on the details?
I see head shakes. There are some plans. I remember visiting some plans in the Massachusetts area that sort of were like the University of Chicago plan, where it started at an academic center and then it later became a Medicaid only plan. And I guess there are some benefits to it in terms of what you can offer to treat your patients. I don't know. I don't know if I would want to answer that question though, in terms of if it would be right for the University of Chicago hospital to pursue. I do know one thing though. Any plan, I think, would have to focus on its patient, the community that it's serving, and be willing to take a loss initially. And with an all-in approach, estimate a time frame for when that will turn around. You have patients who, the goal is your patients are healthier and therefore won't be needing the system as much. And so then you'd hopefully make a profit. But I would say for any entity that planning to go into this area, if they would come to me for advice, I'd tell them, don't go into this expecting to make money initially, or don't go into this expecting to make money at all. But go in it with the intent to help the population and improve their health care. And then down the line, you're gonna, I think, we'll see a greater reward.
Okay, let me open it up now for a little while. See if anyone wants to ask. But
I wanted to kind of go back to talking about 11 and thinking about structural digital. I worked at UChicago Med and we were in the ED kind of trying to figure out, okay, high utilizers, why are they consistently here? Housing, of course, problem. Housing services, which kind of fell within the waivers, was not always the issue. It was, there's just simply demand and supply. Like there's a total imbalance where people are waiting on wait lists forever. Started thinking about like housing development and like, is there a way that MCOs can get involved with like investing in housing and creating? Any
Yes,
thoughts on
yes, there are some hospitals here who have gotten involved in that. I don't know where the status is, but I know, I believe UIC and Rush into collaboration to provide housing, and there are, it's for debate, but there are some private equity firms who've gotten into the mix who are looking into providing housing through this means as well. You know, I know California has had great success with it though. It's a temporary place for people to get on their feet. And then once they're able to, then they help them transition setting. So it does, and the data, early data has shown it's successful. But I believe it's a big investment someone would have to be willing to make.
Yeah, so with like the waiver process, you have 54 different, Medicaids in 54 different states and territories. I think like the good argument is that it creates innovation, and the bad argument is it's like a highly fractured and bureaucratic like federal healthcare system. So like in your mind, how do we like kind of balance those benefits and drawbacks? Like should certain things, in your opinion, be like federally mandated and other types of mandates you're willing to experiment on? I've kind of seen like certain waivers seem like counterproductive to people's health, in my view, in certain states. So what are your thoughts on that?
Well, there are some mandatory things that all states have to cover. So that's one guarantee that you'll see across the board with states. And you're right, a lot of people sort of argue, because there are people who move states because of benefits that are covered in one state that's not covered in another, especially if you have a child with special needs and need services, and one state's a little bit more generous than the other. But you're right, it causes that fragmentation, it causes that great deal of stress in some instances for people. I still think it's a greater reward for allowing states to model the plans or their plans for their healthcare to meet their needs. Because if you think about, compare the state of Illinois, for example, to the state of Arizona. You know, there's a larger American Indian population. And so they have different needs that they may need to address. And so I feel as though if it's, in doing so, the states can have that flexibility. But then, like you said, the flip side of it is perhaps maybe making more things mandatory for states to cover, or as some people may argue, the flip side is just doing universal health care, and we won't, have this problem overall. As you can see, I think in my role at GAL, I always present both sides.
So the work requirements, I guess, under Medicaid, were those pursued through the same waiver process we've been talking about?
You did, it wasn't the 1115 waiver, but yes, you did have
It was another waiver
process that you had to get approval to require.
I just thought of that as the question, is like not obviously related to health, but something the states wanted to experiment with
Yes.
anyway.
Yeah, I worked on Medicaid redesign in the state of Michigan, so it's really cool to hear from you.
I grew up in Detroit, so I know a lot about
Yeah,
Michigan's
cool
program
makers.
too.
Yeah,
Yeah.
I was in Lansing. I'm curious just to like center GAO in the ecosystem and understand kind of to that point, like you are not a lobbying organization, but I was just looking at the website, like you have very important findings. What is your role in educating offices, congressional offices, or members to like advocate for systemic change rather than strictly the oversight function?
Yes, and I should have said, so thank you for the question, that the GAO is an independent organization, so we serve both sides of the aisle. And in working in that independence, but it also means we have independence in our work. They may come and say, we're interested in you exploring X, Y, and Z, and then we take it back and say, okay, this is how we're gonna do it. So they allow us that independence to do how we feel the work should be designed. And it's also in discussing with them about what they may want. You know, sometimes if it's a hot topic question, we have to be sensitive to that because we want to make sure people understand. We're here to present that balance. That's what we do through all of our work. It's now just so ingrained in me. I can't even answer a question without making sure I present to you both sides of the coin. And that's the important role I think that we have to maintain that independence. Our personal views on things can't matter. Whether or not I think there should be universal healthcare coverage is not the question for me to answer to our clients. The question is for me to go get them the information, inform them on how to make that.
I was just curious if your work's been affected by the recent Supreme Court rulings, like the Chevron doctrine one and the overturning of Roe v. Wade.
The questions. All of you have very good questions. We're still sort of unwinding that part because the Chevron, to your question, it certainly goes directly to the executive branch. So we're still sort of unraveling that. Regarding Roe v. Wade, that's something we don't. The judicial branch is their decision. Our work one way or the other. We pretty much are always neutral. Switzerland in that. And just for those, the Chevron would affect us because it affects access to documents. So that's why that one's still kind of playing itself out.
So what's the best route for an innovative healthcare idea to develop? Should there be data, pilot experiments? What's the procedure?
Well, I would think the health policy analysis process is, and I can try to give you a real world example for when I was with the state. We were presented with a problem that we needed to reimburse the CDC for money for immunization for kids. But the ultimate problem was how to work with the state of Medicaid program and the Department of Public Health and pediatricians to provide children who were Medicaid eligible free vaccines. So to do it behind the scenes so that they wouldn't know all the problems that were going on with reimbursement. And I think it started with, CDC calling us saying that we owe the money, but no, it started with patients complaining and doctors complaining that they weren't getting their money and kids weren't able to get access to immunization. And so you start sort of with that problem, policy analysis process, and then the ways to sort of elevate it up. Tons of advocates and lobbyists come into play for how they want to solve this problem. And then you try to think through, well, what are the different policy options? What are the different alternatives that I can do? You think about the pros and cons to each other. And in our case, we had to take it all the way up to the federal level. It wasn't a law necessarily we were trying to get changed. We were trying to change our practices, how we did. And so to me, that's a real life example because that's sort of the policy analysis process. You start with this problem. The question was asked about housing. There's a problem. How do we solve this problem with housing? And then collectively, it can come from the bottom up or the top down. You think about ways to solve that problem. But then it's very important to bring all of the stakeholders involved at the table on what the solution is going to be, then get their buy-in. And it could be you're trying to change a law. It could be you're just trying to change everyday practices or guidance. It could be you're trying to do something innovative and go outside of the system, and then you have to find ways to do that. But the piece that I just want to keep in mind is it starts with this problem. Policy is the end goal, and then you have to figure out what's the best way to get there.
flagged rising costs as an issue facing MCOs out of value-based care. That issue, although to date the results of data path you feel that moving toward, or are there other solutions?
I think we should continue along path of value-based purchasing. And I'm glad you asked the question because I wanted to add something to what Matt said, that it's beyond the metrics within QA, what have you. Their creative means that they're providing to say, okay, if you're able to keep, I don't know, let's make something up, ER admissions down, or, you know, and have patients go and for their primary care as opposed to going to the ER, we'll give you this much amount of money. I think the incentive system is what makes it work for me. And that it gives skin in the game for both sides. And it's a business at the end of the day, and that's how you run this business. You motivate us all with saying, you do good, you get rewarded for that. So that's why I think it's something we should just continue to pursue and just be as creative as possible as we can with the arrangement. We find something.
We as a country, we're going to toward universal health care. What steps do you think would be toward that? What would it be like? Some thoughts I've had are you mentioned research. So if we had a state that had universal health care and then compared that to another state that didn't, to provide some data for providing it for all states then, like what do you think would be concrete steps toward that?
Well, I think somebody would have to have a lot of money because that's what it's going to take. Many states, including Tennessee and Hawaii, as I mentioned, we're trying to take piecemeal approaches. Some of you may remember the state children's health insurance program was another attempt to take piecemeal approaches, to just add on more and more populations. The Affordable Care Act was another piecemeal approach to include adults. So we're adding on more and more population. It seems like in our environment, that's kind of the measure that people are willing to take, just pieces until at some point we're covering everyone. But you've had states, like I said, Tennessee tried that. They even had a policy for what they consider like the uninsurable, those who healthcare was just too high risk or too high cost to be covered by someone. And they provided a plan for this group. So absent coming in and just saying, let's just do Medicare for all, the piecemeal approach just may be the way we do it, kind of inching our way to ultimately have a way that everyone is.
So do you think it's by, so you mentioned breaking down populations by age and then by uninsurable. Is there any other way to think about a piece?
Like me, well, I was just thinking in terms of that's how it seems like it's been going. That it seems like that's the approach that we're taking. I think the only other way would be doing something where we just have, if you're not insured by your employer, then you're insured by the government. That would be the only other way to do it in my personal opinion. But that's why I said you need a lot of money, because then that comes government's dime. Where's that money?
Yeah, I think I think we have to end here. We can take the online question offline. And we're welcome to stay a few minutes for anyone else, but I want to be mindful of people that have to get to class. So thank you all for spending time with us today, and we'll see you at our next event. And please join me in thank you.
All
thank you,
for the
Catina.
people.